Weakness is also an important topic because very often, we always want to venture into newer and tougher cases. Now, the pre-op evaluation, the most important points to really look at is what has caused the subluxation, whether it is a congenital, whether it is trauma or anything else, and the degree of zonular loss. And that decides what kind of a further management you're planning to do, and the location of defect will decide where you're going to sit, where your incision is going to be, and presence or absence of vitreous is going to be very important, because that way you'll keep changing your steps, whether you want to use dispersive viscoelastic or otherwise. When it comes to pre-op evaluation, there are subtle signs that you look for. If it's very mild, the shallow anterior chamber, despite a normal axial length, or could there be a focal iridodonesis, or is it a visibility of peripheral lens equator upon lateral gaze? That is how the degree of zonular weakness keeps increasing. You'll obviously have a decentered nucleus and you don't need to really diagnose it, or a wider iridolenticular gap will obviously say that it's a tough case to really do. When it comes to principles of management, you would obviously want to prevent worsening of the subluxation that is already there, and maintaining a capsular stability for short term as well as for long term is your essential thing. When it comes to capsular support, there are devices which can be used for temporary support or a long term support. It's like iris hooks, which most of us use. Capsule hooks we use sometimes when you have zonular weakness, and all the different kinds of rings and segments and anchors are used for such cases. These are the common pictures. Temporary support rings, of course, they are reusable. There are some specific advantages of that. When it comes to long-term stabilization, you'll have different designs of these CTR or endocapsular rings, like Mosher or Sione ring or segment or Henderson capsule. It's very important to know the timing and choice of insertion. When it is iris capsule retractors, they can be inserted even before the completion of rexis. Sometimes you will have to use them to complete the rexis. But when it comes to these retractors are more effective than CTR in providing temporary support during phacoemulsification. Like when you have a case like this, the incision naturally has to be made away from subluxation, preferably 90 degrees away, to help reduce stress on the existing zonules. When it comes to intraoperative assessment, you look for presence of vitreous, and obviously you have to use dispersive viscoelastic at that time. You have to assess whether there's a need for anterior vitrectomy right in the beginning, and when to use hooks. Surgical principles wise, rexis, it has to be made in an area, it has to start in an area remote from the dialysis to help utilize the counteracting forces of the remaining healthy zonules, and you have to puncture the capsule with a sharp tip needle. Surgical principles, hydrodissection wise, you'll do profuse hydrodissection, and you'll use two instruments to bimanually rotate the nucleus. This is a flow chart of how do you proceed finally to decide whether you're going to only put CTR or you're going to fix the lens, or just use a monofocal lens or iris clip lens. Choice of capsular bag support. The greater the zonular defect, less effective is CTR to stabilize the bag, and for a severe subluxation, you'll use these retractors to hold on before you fix it. When it comes to phacoemulsification, it should be carried out with low bottle height, low aspiration flow rate, and low vacuum. You minimize the movement of the nucleus while sculpting, and in a direct chop, lift the nucleus clear of the posterior capsule and then chop. Cortical aspiration, obviously you will prefer to use a bimanual irrigation aspiration. Now in this case, what I realize is that there is not much of phacodonesis, and that tells me a lot. Here because there is a lot of anterior capsular fibrosis, I do not want to put any stress on the back, so I use a Zepto and make a rexis. And fortunately the nucleus is also not very hard, so I try and manage it. And then first thing I do is put an endocapsular ring. You have to be very careful while putting it, very gentle. And after I put it, I realized that I can just manage to put a lens and still get a fairly central placement, and he may not need anything more to be done. So this case is managed just with endocapsular ring, and because of traumatic mydriasis he goes in for a pupilloplasty. But here the case is different. This is little more extensive, and in this case there is vitreous in the AC, and first thing you do is put triamcinolone, try and do vitrectomy, put dispersive viscoelastic to push and block that gap, and then create a rhexis where the rhexis is as far as possible away from the site of subluxation, because finally when the bag is going to come back into its normal position, the rhexis is going to shift to the center. Either you use iris hooks or use capsular hooks, and here ideally you have to use capsular hooks. You do copious amount of hydrodissection, get the nucleus out, again repeat hydrodissection, and then do bimanual or coaxial to get the complete cortex out. And before late you put an endocapsular ring so that equatorially you have stretched the capsular back. And then what I have done is I have created Hoffman pocket. Now Hoffman pocket is a simple thing. You take a 300 micron depth blade and create a groove on the limbus and dissect it reverse way. The only purpose of doing that is to avoid suture knots coming outside. And now I used a 9/0 STC suture 9/0 on STC needle. You come in from outside, get the needle out, use hammer segment, thread it through, and then use a railroad technique where 26 number needle goes from the side of the original puncture, and now the needle is pushed back and taken out, so both the suture ends are out. After that, I'll hurry through. After that, the suture is pulled and the hammer segment is gradually taken, and with the convexity outwards, it is tucked into the bag with the central eyelet and that portion above the rhexis margin, and try and pull it and make a temporary knot, because you still have a lot of viscoelastic in the eye and in the bag, because you need to put your lens very gradually. It takes a lot of time for the lens to get properly tucked into the bag, and then remove the viscoelastic, constrict the pupil, and then tighten the knot so that the lens is in place. And here a similar weak zonules with subluxation, I go about it normally, but because of the phacodonosis, I managed to get the needle out well in advance before the phaco is done. But this time, instead of segment, I use an ASIA anchor in the similar manner, but this anchor has several advantages over the segment, and it's like a clip, so it is in one plane. So at the end of the surgery, when you tie the knot and get the pupil in, it doesn't get stuck onto the iris, and because of traumatic mydriasis, this patient needs pupilloplasty on either side, and at the end of it you have it. So these were some of the cases of weak zonules, and I would really like to thank all of you for staying on till late for this course. Thank you so much, and I would like to thank my faculty for giving real wonderful insight into the topics that you chose. Thank you so much.